So, what percentage of patients who come in with that same, let's just use my analogy, we'll just run with this for a minute. A person that's saying, I hurt when I raise my arm overhead, we find a trigger point that seems to be active, it's reproducing their concordant symptom, that their primary complaint is you've ruled in that it's appropriate to needle that area. What percentage of those patients that have that complaint might you say, all right, it's appropriate and even important to needle this area?
Yeah. So percentage wise, I really couldn't say what that percent is, but if somebody has an active trigger point and you find the muscle that reproduces the anterior, for example, the infraspinatus is a common muscle that's in trouble in many patients with shoulder dysfunction. So I go ahead and palpate that infraspinatus, patients there because they have a bicipital tendonitis. I do my active passive resisted testing on the biceps and it's all inconclusive or negative. I do my speeds test and maybe it's painful, but not reproducing the patient's pain. If I don't look at that infraspinatus, which can cause pretty significant anterior shoulder pain in the same region as a bicipital tendonitis, if I'm not aware of that referral pattern, I would never look at the infraspinatus as being a cause of anterior shoulder pain. But the infraspinatus is a very common muscle in upper and shoulder dysfunction that's very common to have trigger points in it. It's also very common to have trigger points from cervical radicular pain because of the outflow of the neurokines into the target tissues from the nerve root level. So if you looked at infraspinatus, it's innervated by C5, C6. When I was in Atlanta in the clinic more than I am now, we had colleagues that we always said, patients came in with cervical radicular pain. They have that raging arm pain. You've seen them. We use a lot of, whether it's McKenzie, whatever you're doing, specific directional motions, mobilization, you're doing an eclectic approach to manage the person's radicular symptoms. And let's say they go for an epidural injection, transfemoral epidural spinal injection. They come back and they're feeling good. And then they have that residual ache in their upper extremity. And this is just anecdotal. We have found that if you went in there and identified trigger points, if they were present in the infraspinatus, that if you needled the infraspinatus in those patients, their arm pain went away. For some reason, the dorsal root ganglion does not get the message that the acute inflammatory process in the nerve root is over, and it's a self-perpetuating phenomenon of pushing out CGRP and substance P out to the target tissue, which would be the muscle itself. And it's very common to have that muscle stay in trouble for a long time. So that to me is one of the hallmarks, or the naysayers of the world, if they would just take a step back and say, no, it's not the end all and be all, but are using a sound clinical reasoning process and understanding peripheral nociceptive or peripheral neuropathic neurogenic pain and what's happening at the neural tissue level and how trigger points are affected by antidromic and orthodromic axonal flow. And especially substance P and calcitonin gene-related peptide, which are produced by the dorsal root ganglion cell body of the nerve, and it's pushed out not only into the spinal cord, but it's also pushed out into the target tissue in the periphery. So it's really understanding the depth of the science that goes with needling and trigger points and pain sciences.
Clearly, I think you're right. Because you're able, this so well, sounds like. At least you're really doing a good job of pulling my leg. I'm kidding. But do all people that utilize dry needling, can they understand it to that degree that and do they? Not well, can they, but do they?
I think one of the things that, as a profession we struggle with is truly a sound clinical reasoning process. And a lot of times people confuse clinical decision-making, clinical judgment with clinical reasoning. And clinical reasoning truly is the organization of your knowledge, right? And it's reflective inquiry. So every patient needs to be an N of one. And that patient in front of you is a scientific experiment. And if you are a clinical scientist, you will confirm and negate your hypotheses and test and retest what you believe. And you will also test out the alternative hypothesis. So that's kind of how I approach when I'm teaching dry needling. That's how I approach it. I'm very heavy into the pain sciences, but more importantly, the clinical reasoning process. And I was trained at the University of South Australia with Mark Jones, Mary McGarity, Ruth Grant, Jeff Maitland School. And that's the one thing that I took back in 1995 was after 10 years of practice. If I would have understood that clinical reasoning process in managing patients, I wouldn't have been fried at 10 years of clinical practice.
Okay.
So one of my strategies for teaching truly is clinical reasoning.
Right.
Because any monkey can look in a book and learn a technique, and that's a fact. Monkeys can look in books and reproduce a picture in a book. But as physical therapists, we have to have a sound clinical reasoning process that integrates the evidence, contextual factors, and patients' values and circumstances into the treatment plan and into the thinking process. And we have gone to this extreme of judging everybody, and every patient's an N of one, and every patient deserves a sound clinical reasoning process to help them through the rehabilitation process, or to help them figure out strategies for home management. And we found that now with the advancement of the pain sciences. Right?
Yeah. Yeah, we're in agreement, by the way, and I think most listeners would agree with that every patient's an N of one, and with every patient, we should be thinking, okay, what could this be, and what could it not be, based on what I'm seeing from a historical perspective, from what they've told me, and then from what physically I'm seeing in front of me, and how they're responding to whatever the intervention or the movement or the position is. Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.